So I gather you hear me. And I'm really honored to be here. And I was really inspired and amazed by all of your presentations. And I'm just a small drop in this ocean of knowledge, and I've learned a lot. And I think my presentation is a little bit easier on the knowledge. But I would like to ask you to keep your expectations a little bit at bay, because from the title I gathered that you expect some amazing or I don't know, huge results. I can't give it to you yet, but you will see. So I will start from the last word in my title, Lithuania. You already heard this name throughout this conference because I said I'm from Lithuania, maybe somewhere went there. Some people told me, yeah, I know, you are great in basketball. And we can say that in Lithuania we have at least two religions. The first one is Christianity, the second one is basketball. I would like to say that I believe now the third one is throwing discus, because we have a dynasty of discus throwers. You might recognize these guys from the Olympic Games, silver, gold, and bronze medalists, and this is the father and son duo. Going back again to the map, you can see Lithuania on the map, and we are a small country. There is less than 3 million people at the moment. There was a lot of emigration some 15 years ago, although World Happiness Report said in 2024 that under 30s in Lithuania were the happiest people on earth. It's not true anymore. I don't know what happened. Maybe it has to deal with the next sentence, that we rank amongst the lowest fertility rates in the EU right now. I don't know. And it is like a national topic in the politics, the demographic problems, with total fertility rate of 11.11 children per woman right now. And our delivery rate, births per year, are constantly dropping, and in 10 years we had a decrease of about 30%. So it's a dramatic decrease, even though at the moment we are one of the top countries that have most of their people that have left the country coming back. So maybe it will get better. Maybe next time I will say, yeah, we have the change. And a little bit more of the background. I think that we have quite a good perinatal mortality statistics, and at least we are in the decreasing zone all the time. And regarding newborns born in hypoxia, I have the data from 2024. There were 254, and 16 had hypoxic ischemic encephalopathy, which is quite a low rate. Maybe it's just this year, maybe we had more the previous year, but I think it's quite a good number. Zooming in from the country to the city I come from, it's Kaunas. It's the second largest city in Lithuania, and this is the hospital that I work in. It's Lithuanian University of Health Sciences Hospital Kauno Klinikos, and it is the largest hospital in Lithuania. It was established in 1940 with a lot of clinical departments, affiliated hospitals, and it's second largest employee in Lithuania with more than 8,000 employees. And a little bit about the care. We have two perinatal centers, Kaunas and Vilnius. Vilnius is the capital. You see the division on the map. I come from Kaunas, which covers 3/5 of Lithuania. And with that coverage, we have the most deliveries per year. And in 2025, it still was already less than 3,000. The C-section rate in our institution is 27.7, and it's not something that we are really happy about. Half of them, almost half of them, are elective. As you can see, about 16% are due to fetal compromise. Ventus or vacuum extractions are not so common as in Scandinavian countries, I would say. And more of them are due to fetal compromise than maternal fatigue or slowed second stage. And about 70% of these babies that mothers had a C-section for fetal compromise come in good condition, which is good for the babies, but maybe the intervention was not necessary. So that's where we want to become better. And with ventouse deliveries, you can see the good condition was quite more rare, but what is good condition after all? We had discussions about pH, about short-term good condition of the baby, long-term, so it's still a question to answer. And the national C-section rate is 24%, 24.3. Unluckily, it's increasing 0.4 points per year. A lot of reasons, maybe the older age of the first-time mothers, additional diseases to the mothers like hypertension and diabetes and so on. Regarding fetal monitoring, we have our national guidelines, which were developed in 2018, and they are mostly based on FIGO. We classify into normal, suspicious, or abnormal, and this is in the national guidelines, but more and more we are adapting physiological CTG to our practice. It's not yet in the guidelines, but it's not contrary to the guidelines. We can use them, so we are using it more and more. And I was really impressed by presentation about from Sofia from Germany about lower rates of fetal hypoxia with this, and of course Dr. Susana Pereira. So I'm really grateful that we can have it. And we are no longer using fetal blood sampling. It is allowed, but it's not a strict recommendation, and it is decreasing in the usage. So how I got here, why I am here, and how it started, I actually don't know. I was lucky enough to be contacted by my supervisor, which you can see in the middle. This is Associate Professor Justina. She contacted Antonia, and they said, yeah, let's meet and let's try to see what we can do together. So we went to Oxford in 2022. We went to a meeting. We were really, really inspired. A whole new world has opened up in front of our eyes, coming from such a small country. And after that, we conducted a patient survey back home. We asked the patients what would they think about AI in CTG monitoring. Of course, we asked about their education, about the region, is it rural or a city, where they live, the age. We asked if they know at all what is AI. Then we described what is AI and asked them if they were correct in thinking about AI. We also described what is CTG and how it is used in labor to monitor the fetus. So you can see a lot of patients were informed about AI, less patients were informed about its use in medicine. And of course, patients with higher education were more informed about it. And there were also about 15 questions regarding specifically CTG. And I would like to highlight five of them. So generally, patients would agree that the doctor is using AI. For CTG interpretation, they are not against it. Of course, they would want the general conclusion made by the doctor, the decision made together with the doctor. They would trust AI for evaluation of CTG only if its benefits is scientifically proven. And luckily for us, the doctors or midwives, they don't think that AI will overtake doctors' work in the future, so we will not be unemployed. And what about the doctors? I don't have an official survey, but to us, computerized CTG is still some kind of magic. We hope that there is an app or a program that at any time of labor gives you an alert, or if you are not sure, you can just consult with that program and it will say your risk is this, your risk is higher, your risk is lower, then you can discuss with the patient. Unfortunately, we are not there yet, but I will not surprise you. We would also love to detect compromised fetuses earlier and reduce the rate of instrumental delivery, unnecessary instrumental delivery as well. And currently, we are, thanks to Antonia, thanks to Chris, collecting data on patients during delivery. So in the beginning of the study, we had the monitors which are printing out the CTG. We don't have electronic record of that. We did not have it. So we had to have an app installed into a tablet, and then the tablet connected to the CTG monitor. And when the patient is in labor, she is in the delivery room, and the tablet is connected, and we are collecting clinical data, CTG trace, and the outcomes. And currently I have only 121 patients in contrast to the thousands that you have tested. And this is the clinical data of my patients. You can see a lot of induced labors. Well, we are a tertiary care unit with the risky pregnancies in the end. We have diabetes rate of about 40%. In general, the rate in Lithuania is about 20%, hypertensive disorders, and the mothers are mostly between 20 and 35 years old. Regarding the outcomes, in this 121 patients, there were no cases of severe compromise as could be described as long-term, ventilation, free cold applying to the baby after the delivery. I described intermediate compromise, as you can see, with pH lower or equal 7.15 or 1 minute of Apgar score less than 7, or some kind of special care, and we had 13 cases of that. What is different regarding delivery modes? We had more than 2 deliveries in this group of patients than in our hospital usually. And almost half of the indications had something to do with fetal compromise, either purely fetal compromise or fetal compromise paying some influence on the decision because the labor is progressing slowly, maybe the baby is not well, and let's go for instrumental delivery or C-section. So that is where we would like to get some help. I looked into those who have been under instrumental delivery because of fetal compromise and those who had delivered spontaneously, and you can see that we have worse outcomes in those who were not delivered quicker, but it's something to look on later. These are the babies, since there were not a lot of them that had some problems later on, but out of them you can see for congenital infections, maybe that could have influenced the Apgar scores, let's say, and I think the worst baby is on the corner with normal pH, but on neurosonogram it had intraventricular hemorrhage, no neonatal infection. And I think what is the most interesting are the results for fit for labor. And thanks to Pavel, I now have 60-minute trace scores for 80 of my patients. And at the moment, the beautiful tables are pending, but I try to see what is the number, the score, if it's higher in the compromised babies. And yes, the tendency is that it is higher. But with the small sample, it's not clinically significant yet. But what I hope is with current situation, since February we have Philips IntelliSpace perinatal and the ability to collect electronic medical records. So I hope to have more data, of course, and I would also be very interested in the risk score later in labor, not in the beginning, but at some point later in labor. And I would like to thank you all for your attention and for all your presentations and experiences. I learned a lot here. And this is Kaunas, by the way.
Thank you, Migle. Question, Martin?
Thank you. Yeah, thanks so much. It's a beautiful background and exciting to see that you're standing up things in this way. And as you do this now, you have an opportunity maybe to do some things in a different way than institutions that have established approaches. You have an advantage. So I'm just asking myself if you're looking into connecting the dots more comprehensively from antepartum to the pediatrics. That's a common issue, right, that we see across
yeah.
institutions.
Yeah, so at the moment I can like manually connect and check the babies. What is Lithuania doing right now? A system for a whole pregnancy, delivery, and neonatal result is being created. It's a year or two into implementation, so there are statistics that can be taken out, so a database is being created, but it's the beginning. So the connection is really, really important. At the moment it can be only done manually, but hopefully we will have it in the future.
Okay, thank you. Any other questions? I was wondering, you have really low vacuum assisted delivery percent, 2 point something. Is it possible that it is the driver of this increased cesarean section rates, or do you think that it's just that mothers are not so healthy anymore?
It can be. It can be. I think that it's like maybe lack of experience with vacuum extractions. There are some doctors who are really confident in that, and some who are not that confident. We have constant inside courses, but still, in the end, some just prefer C-section, and sometimes women are afraid of vacuum extraction.
Okay. Thank you, Migle.
Thank you.